Welcome to PodcastRx, a new monthly podcast from Diamond Pharmacy Services.
Each episode is a conversation with the men and women who make Diamond the nation's largest correctional pharmacy provider, Pennsylvania's largest independently owned long-term care pharmacy, and a trusted retail pharmacy and medical supply provider to many in Western Pennsylvania.
We chat with pharmacists, nurses, technicians, and other key personnel for a deeper look at the administrative, clinical, and logistical challenges of filling prescriptions and delivering healthcare, from our local counter to across the country.
And we also get the occasional glimpse into the professional journeys of our guests and why they chose the careers in pharmacy and healthcare.
During 2017, there were more than 70,000 overdose deaths in the United States, and of those deaths, over 47,000 involved opioids. More than 130 people died every day from opioid-related drug overdose in 2016 and 2017, and that's according to the U.S. Department of Health and Human Services. According to market research, prescription opioid volumes peaked in 2011 with the equivalent of 240 billion milligrams of morphine prescribed. That volume declined to about 171 billion milligrams of morphine in 2017, which is about a 29% drop. Because of these staggering numbers, it's no surprise that anything relevant to treating opioid addiction is a hot topic. Today we're going to be speaking with Chris Bender, who's a PharmD and part of the Diamond Pharmacy Services Drug Info Center. We're going to talk about medication-assisted treatment of opioid addiction. It's at times a controversial topic for some reasons we're going to outline today. We're also going to go over the clinical nature of how this treatment works, how these programs can have a positive effect, and talk about some regulatory hurdles that come with this form of treatment. Welcome to PodcastRx. I'm Ashley Fritz. Hi, Chris. Welcome to the show today.
Hi, Ashley. Thank you for having me.
We're really glad you're here. We're going to be talking about a topic. It can be at times controversial. I think it's general interest as well as relevant clinically. We're going to talk about medication-assisted treatment of opioid addiction. I know in preparation for this episode, I read a lot about this, and admittedly, it was a topic I was moderately aware of, but really opened my eyes when I started to read into this, not only the population this could help, the controversy behind it, the regulatory hurdles you have to overcome to even get involved in it. So let's just start out for our listeners. Can you tell us what exactly is medication-assisted treatment for opioid addiction and how does it work?
Yeah, so that's a great question. Medication-assisted treatment is actually one component of the overall treatment of opioid use disorder. I think it's important that we lead in with that, because medication is not everything in this case. So what I mean by that is essentially MAT, as I'll refer to it throughout the remainder of this, MAT is the use of medication to kind of help subside or treat some of the symptoms associated with opioid use disorder, which basically allows the individual to learn the psychosocial component of living in recovery. So what I like to think of it is it kind of puts the patient on a better baseline in order to better handle the stressors and cope with life in general. So moving into the types of MAT, essentially we have three options. Those three options are methadone, buprenorphine, and naltrexone. Of those three medications, two of them sort of mimic the effects of the opioids, mimic the effects of a street drug like heroin or prescription opioids like oxycodone, whereas the other medication, naltrexone, blocks the effects of those medications. So we have a couple different treatment pathways that we can use when it comes to using medication.
Now, one that I think most of us have probably heard of would be methadone. I mean, I feel like that's something that I've been hearing for years, yes. But some of these others I really haven't. So are some of these like a newer tactic?
Oh, yeah. Yeah. So methadone has actually been available in the U.S. since 1947, I believe, the 1940s. It was originally used for pain. We found that because it works so long, however, that it can actually be used for the treatment, the maintenance of opioid use disorder. Now, it's the other medications, the buprenorphine, the naltrexone, that have kind of come onto the market a little bit more recently. Buprenorphine is something that came out in the 2000s under the brand names Suboxone or Subutex. Many may be more familiar with. The naltrexone is a little bit older. It's sort of in between, a little bit newer than methadone, a little bit older than buprenorphine. But it really came into light whenever it was made into a long-acting injectable formulation called Vivitrol. Mm-hmm. And when we're talking about MAT, that's kind of the one that's being touted a lot whenever you talk about naltrexone.
Right. And something I definitely not understanding even about like somebody who was going through methadone treatment, that's something that 9 times out of 10, they're at the clinic daily, maybe multiple times a day to be maintained.
Yeah. And that's one of the biggest hurdles of using methadone. So you're right. Whenever you are initiated into a methadone treatment facility, you're going on a daily basis. And of course, this is because they're not allowing you to take any medication out of the facility. It's a directly monitored type of program. So they'll generally give you the methadone in a liquid form, and they'll monitor you taking that medication. But more than that, they also are required to have programs to help treat, not just use medication, but also do the psychosocial, so therapy programs as well within these facilities, as well as physician or provider monitoring. So yeah, you have to go on a daily basis, and it's only at a certain point. I want to say I think it's at the physician's discretion, but it can be a year, it could be 2 years. If you've been maintained on this medication for so long and you've done well on it, you've had negative urine screens for other substances, then they start to allow you the ability to have take-home doses. And it's only at that point that you're allowed to go maybe a day or 2 without going to the facility, but you're still going on a very routine basis.
So is the end goal, somebody who may be on methadone, is the end goal to be weaned completely off of it, or is it something that you could potentially maintain for the rest of your life?
It really depends on who you ask. Yeah. So if you're a highly motivated individual, and if you would speak to a provider, I think the ultimate goal would be to end up off of the medication one day. But I say that it depends on who you ask, because for some people, they may not be able to get off of the medication. But an ideal goal would be to get on a dose that's low enough to where it's not producing any effects such as euphoria or sedation, but it allows them just to basically maintain their lives. And by taking care of the baseline needs, they're then able to focus on the other aspects of their life.
Sure. And because of the potential of what you're saying about to ensure it doesn't create a euphoria or anything like that, are there potential for any of these drugs to be abused?
Yes. So there are, and that's one of the major concerns, especially whenever we're thinking of the general population, but more specifically the correctional population, because methadone is what we call a full agonist, meaning that it works the same way that oxycodone would or like heroin would. The more you take of the medication, the more of the effects that it tends to have. So it is possible to take more of the medication and to receive more of the euphoric effects. However, that's why it's given in such a tightly regulated fashion.
Right.
So we're able to monitor. They're being observed by a nurse at the facility. And as long as no diversion occurs, of course, and hoarding or anything like that, then that dose is going to be all that they receive. And the idea being, we provide them with one dose for the whole day that provides neither sedation or euphoria, but also staves off any of the withdrawal. I tend to like to call this the Goldilocks zone, or the Goldilocks dose. The other medication, buprenorphine, so this is what we call a partial agonist. So what that means is it kind of, if you think about it like a ball and chain on a door, it will open the door, but only to a certain extent. Meaning you're going to get some effect, some opioid-like effect, but only to a certain extent. Meaning you can only take so much until it reaches a ceiling. And generally speaking, that's around 24 to 32 milligrams per day. So even if you were to take a ton of the medication, it's only going to have so much of an effect.
So the effect will level off regardless of the dose after a certain
Absolutely.
point.
It plateaus. Mm-hmm. So that's why in recent years, buprenorphine has been, I would say, an up-and-coming one as opposed to methadone, which has been historically the big player.
Sure.
Buprenorphine has been found to be a little bit safer, as well as because of that ceiling effect, people are a little more comfortable letting people use this medication.
Sure, I can see that. So let's talk about the effectiveness of these. What is the research showing? Like, is this effectively treating folks who suffer from opioid addiction?
Yeah, so generally what we see in clinical trials is that treatment with a medication that stimulates the opioid system, so methadone or buprenorphine is more effective than abstinence alone. Generally speaking, you're going to get a lot of differing results based on different clinical trials that you look at. But in some of my research for various presentations, I found that on average, methadone retains about 70% of patients in treatment. Buprenorphine does have a bit of a drop off. You do see about 40 to 50% of patients staying in treatment. But still, that's a very considerable effect size in these patients versus just pure abstinence.
It's significant. And even, thinking about the numbers that we mentioned in the intro of the podcast, the number of people who are dying because of opioids, it's absolutely astronomical. And so if it's even affecting half of that, it's incredible.
It's a win.
Yeah.
And one of the things that I found that was kind of in stark contrast to those results was in a study they found where if you detoxed someone, meaning you took them off of the opioid completely, and then you treated them, quote unquote, treated them in an abstinence-based program, meaning you did not give them any medication, no buprenorphine or methadone. You just treated them with a therapeutic approach. 60% of all patients relapsed within 90 days. So it's a very quick, very steep drop-off of patients if you're only relying on an abstinence-based program.
Wow. So there's another option that you mentioned earlier on in the podcast, the Naltrexone, which acts a little differently than the other two. It's a blocker.
Yes.
So can you explain kind of what that means and talk about the effectiveness of that?
Yeah, absolutely. So the Naltrexone that we're talking about, there is an oral formulation of, but in our population, we tend to see a lot more of the long-acting injectable formulation known as Vivitrol. And this blocks the effects of opioids, meaning it enters the system, it binds to the opioid receptor, and it completely shuts the system down. So any outside sources of opioids, whether it be from prescription pills or from heroin, it's not allowed to block or not allowed to bind to the receptor. So a lot of people like this option from a outside standpoint, from a regulatory perspective, because it isn't associated with the same stigma as the other two medications. Because a lot of the other two medications, buprenorphine and methadone, are often misclassified as just replacing one drug for another. So a lot of people think this isn't a narcotic, this isn't giving them the drug, this is a safer, better alternative. So with that said, it is an effective treatment option. I tend to think of it as more of a tool for someone who's highly motivated, someone who says that I do not want to use opioids anymore, and I will abstain from them. Whereas someone who might need a little bit more of a softer landing, something else to help them along their path, they may need more of a methadone or buprenorphine. So essentially, the Vivitrol injection is given once a month. And the only problem with the injectable Naltrexone is that over the course of that month, these patients are not consuming any opioids. So as we know, whenever you stop using a substance, your tolerance goes away. Because we know that as patients use opioids long over time, they develop a huge tolerance. They have to use higher doses. Whereas if you no longer are using over the course of a month, your tolerance decreases. And say a patient decides after the 28 days is over and the Vivitrol wore off, they're not going to get that next dose and they're going to go back to using heroin. If they use the same dose of heroin as they were on day zero, then they're at a much greater risk for overdose.
Understood.
So that's one of the complicating factors with that. You have to make sure that you have a very dedicated patient population or a very vigilant support group to make sure that these patients go to their follow-up appointments. Because if it is used regularly, it is also just as effective as buprenorphine. Head-to-head trials have shown that Naltrexone injectable is just as effective as buprenorphine. It's just the fact that getting them onto the injection for Naltrexone is kind of the difficult transition period, because in order to get onto Vivitrol or Naltrexone, you have to be opioid free for anywhere from 7 to 14 days, which is a very fragile, delicate period for someone.
And I would think that is when the withdrawal symptoms are at their absolute peak.
Exactly. So if you can make sure that a patient has been without opioids for 7 to 14 days successfully, and you can get them onto the Vivitrol injection, then it becomes a very effective tool. It's just, like I said, the clinical trials between Vivitrol and buprenorphine showed that overall, buprenorphine was better, but that was only because you lost a lot of people before they even got a chance to get on the Vivitrol injection. They just left the trial over those 7 to 14 days.
We're going to take a little break now to tell you a little more about the Diamond Drug Information Center. On a personal level, we all appreciate when our pharmacist gives us a thorough consultation for a new or complex medication. They dispense not only the drug, but important information about dosing and possible interactions. This kind of medication counseling is easy to understand on a personal level, but what about on an institutional level? Where do healthcare providers, especially those delivering care to large populations with diverse needs, go when they need medication counseling? Enter the Diamond Drug Information Center. The pharmacists of the Drug Info Center dispense in-depth clinical consultation for all of Diamond's customers, from correctional facilities to nursing homes. This team of PharmDs specializes in pharmacotherapy and disease state management. And if you have questions about dosing, drug-drug interactions, non-formulary medication requests, therapeutic alternatives, or you just need general clinical advice, they're a call away. They also take proactive steps to educate healthcare professionals. They issue regular clinical updates, and they develop webinars and presentations about specific drug topics. You can reach the Diamond Drug Information Center at 800-882-6337, extension 1834, or email them druginfo@diamondpharmacy.com. And now back to PodcastRx.
Welcome back to PodcastRx. I'm here with Chris Bender today. We're talking about medication-assisted treatment for opioid addiction. And Chris, you said something really interesting in the first segment about how about basically getting a patient to baseline. And I think a lot of us tend to misunderstand somebody who's struggling with addiction and why they continually take the opioids. And I want to read a quote from a 2017 Vox article. And it says, one of the reasons opioid addiction is so powerful is that those in its grips feel like they must keep using the drugs in order to stave off withdrawal. Once a person's body grows used to opioids but doesn't get enough of the drugs to satisfy what it's used to, withdrawal can pop up, causing, among other symptoms, severe nausea and full body aches. So to avoid suffering through it, people often seek out drugs like heroin and opioid painkillers, not necessarily to get a euphoric high, but to feel normal and avoid withdrawal. And I think that's a really interesting distinction to make. Mm-hmm. And I think that's something, if somebody has never had that struggle in their life, they don't understand that. So the idea of getting somebody into these medication therapies, even something that you have to like detox for 2 weeks before you can get on, it can be a challenge.
Exactly.
And I guess my question would be to you, and I'd like your perspective on it, because I read a lot and I heard a lot of objections to this therapy. Some were relevant, some bordered or very irrational. But the numbers show that this works in treatment of opioid addiction. So why do you think so many people are against this therapy?
I think that a lot of people just simply don't understand it from either a firsthand or close to. It's getting more calm from a firsthand or someone close to you perspective. Unfortunately, it's becoming more common these days, opioid use disorder and addiction. So I think as time goes on, people are getting more familiar with this concept. I know, being from a small town, a lot of people have the closed-minded approach and think this isn't necessary. Just stop it. Why do you need to keep using this? But even in my small town, multiple people have become affected by addiction, right. And it has finally started to touch so many people. And I think that once people see firsthand, they really start to understand that it's not necessarily giving one drug for another. It's not about facilitating someone's party. It's about bringing them back to a baseline. Like I said before, I think that quote from that Vox article really summarizes it. Really summarizes it very well, because I feel it would help people conceptualize it if they could think about it as using antidepressants, right? So the way I think about it is, antidepressants aren't there to make you feel happy, as opposed to what those 90s commercials would make you think.
You're absolutely right. Mm-hmm.
You don't take that medication and feel amazing the very next day. The antidepressants are there to help you get a more level playing ground so that you can benefit more from psychotherapy and help better your environment around you. Much like antidepressants, these medications for opioid use disorder help kind of balance the playing field a little bit, give you a better foundation. Because if anyone out there is familiar with Maslow's hierarchy of needs, we're not able to focus on the upper rungs of the pyramid until we're able to focus and have secured our baseline physical human needs, food, water. Over time, as we use, or as a patient uses opioids or just drugs in general, that becomes as important as food and water in order for daily functioning.
Right.
So if we're able to plug in that piece of the puzzle and secure that lower rung of the pyramid, they're then able to focus on getting more out of their therapy, improving their social setting, and then working on the next levels from there.
And I think it's interesting to note, when I was reading of folks who were very, very for this kind of therapy, their point was really valid when they said if there was any clinical trial for any documented disease that was getting the kind of numbers and success that this was getting, it would be celebrated as a clinical success. Yes. And it's only been recently, and I would even say in the last decade, that thankfully we're looking at even something like mental illness as a disease to be treated and not just something you need to snap out of and get over it. We're finally treating that appropriately because we're looking at it as a disease or a disorder. And basically the point is we need to start looking at addiction that way. So do you think we need to change the way we look at addiction?
Yeah, absolutely. And that's why I think in the most recent iteration of the DSM-5, which is the manual for diagnosing psych disorders. Opioid use disorder is listed in there among other use disorders, substance use disorders. And I feel like that's the impetus for anything. Once we have a valid diagnosis in the books, then we're able to better get, for better or for worse, payers on board, institutions on board, right. And eventually all of those in place will help to shape societal's input on that. Because you're right, if you would get any other type of results for any other medical conditions, everyone would be ranting and raving about it. Mm-hmm. If you could have a 70% reduction in cardiovascular events in a diabetic patient by taking this one pill every day, I think that people would be paying tons of money for this, and
Absolutely.
you'd hear it all over the news. We hear MAT in the news as well, but not always in such a positive light. Yeah. But you're right. If you would have those results from anything else, you would not be getting any mixed results.
Right. What I found interesting also in reading about this is the objections. It's not even just among the general public. It's not among just clinicians. It's among folks who are struggling with opioid addiction themselves. Mm-hmm. And something very common, I think the whole approach of like the 12 steps, the abstinent program has been so ingrained in people's minds that that's how you do it. And if you have somebody that overcame an opioid addiction that way, that is an incredible achievement. Mm-hmm. And that deserves to be celebrated. But then some of those folks don't support this kind of treatment for one reason or another. What are your thoughts on that? Absolutely,
yeah. And I think what I would say is that not every way works for every person. I do know that in the people who participate in 12-step programs are very adamant. I've heard and read many things where they tend to believe that a person using one of these substances is still not clean and sober, and they're not truly in recovery. Right. And I think that may come down to the fact that they either A, they feel like they're using a crutch to do it, or B, maybe there's some inherent belief that maybe they're misusing this on the side. And I think that's natural. But if you have someone who's using it appropriately, who's being monitored appropriately, and who's having the same end result as someone who's doing the 12 steps, then I think all things should be equal.
Right.
So long as they're not misusing the medication, it doesn't matter what you're doing to get there. You're both at the same result. And yes, it would be nice to eventually get off of the medication, but if someone would have to take it daily for the rest of their lives, people do that across America or across the world.
Any number of things.
For anything, for
right.
hypertension, for diabetes, and that's not abnormal.
It's about preservation of life.
Exactly. I just think that a lot of people tend to think, well, I didn't need to do it that way. So my way, it tends to be best, right? So I think there is conflicting viewpoints out there. But I will say there's no clinical trials out there that show how effective 12 steps are either. So it's something that we have hard data for using these medications. And if they're working for someone, I think that's effective.
Well, that is just it. And I mean, I think your point is valid. This definitely isn't a one-size-fits-all approach. Even among the three main therapies we've discussed today, what will work for some won't work for others.
Yeah.
And unfortunately, some people, none of these will work.
Unfortunately.
But it's just basically trying to present options. I mean, this is what we're seeing with the opioid addiction crisis in this country and the overdose deaths in epidemic proportion. I think this health crisis has flown under the radar far too long. And now in the last few years, as it's come to light, I mean, anything we can throw at it to try to make a dent is going to be important.
Yeah.
And important to note, too, talking about, we're certainly not downplaying 12-step programs. There's validity there. But there are, referring back to that Vox article, there were certain divisions of the Betty Ford Foundation that are utilizing these therapies, the medication-assisted treatment as well. And so I think across the board, maybe it's starting to be a little bit more accepted. Now let's talk about, we work primarily in a corrections facility field for pharmaceuticals. Do you see this kind of coming more over into corrections?
Yeah, I don't see how it doesn't. I was, in preparation and just even through my daily work here, we get a lot of questions on a daily basis from facilities about incorporating more of this on a day-to-day basis, how the best way to incorporate it would be. It's hard for them not to become part of this whole paradigm of treatment. I have to say it. You have to feel for them in a way, because they weren't jails, prisons. They weren't initially designed for this.
Sure.
So that's why it's really hard to start to implement these things whenever the staff don't necessarily have the staff or maybe the resources. But I do feel that unfortunately we've come to the point now where it has to be started somewhere. What I was in preparation for this, I saw a couple good articles, and I think what really is most important is not necessarily the jails or prisons being the sole ones shouldering this burden, but rather it should be a coordination of efforts between the jails and prisons and the community. Because a lot of times, at least with regard to jails, it's such a short stay that sometimes it's difficult. The only thing you can do is really just get them detoxed and medically manage them through their withdrawal. So the most important part is getting them started on an MAT treatment prior to leaving, and then getting them coordinated and hooked up with someone on the outside so that they can continue that.
There needs to be an aftercare plan.
That trip home has got to be one of the most dangerous trips they can make.
Of course. Well, then as you mentioned, if they go with one of the therapies that blocks the opioids from the system, they're at a far higher risk of overdose if they would take a dosage they were taking before ever going on the medication.
Exactly.
Yeah. Something interesting, I was reading an article from the Union Leader, which is a newspaper in New Hampshire, and the article was about how they were talking about overall how some prisons were bringing this therapy in and kind of trying to make it a more regular course of therapy. But what I thought was most fascinating is that Suboxone is one of the most frequently smuggled drugs into prison. It's quickly become the biggest source, the biggest contraband item in prisons and jails. Yeah.
It's a difficult situation to be in because you want to use this, but you also don't want it to fall out of the hands of the patient and into the hands of another, a non-patient or just a casual recreational user.
Right.
Because while the medication isn't designed to create a high in someone who's already been pretty tolerant and use opioids, in a casual user, it can still cause quite a bit of euphoria. So a lot of people, this is a highly sought after thing. So that's where we're finding a lot of our difficulty in incorporating this into the correctional facilities, is how can we safely use this? Because I think a lot of people are on board with, yes, let's do this. It's just how can we do this safely? And a lot of it comes down to direct monitoring of patients when they're in the facility clinic. I know there's a lot of logistics that go into this. They have to sit on a chair. They have to make sure they don't reach for anything.
Right,
They can't
right.
cheek any of the medication. And some of these products take up to anywhere from 5 to 10 minutes to dissolve when in the mouth. So logistically, it is difficult, I will say.
Yeah, I can see why it would be something hard to implement. Even if the will is there, sometimes a way might not be able to be made just because of time and coordination of efforts. Fascinating topic, and I can see why there's controversy surrounding it on all sides. But I think we can agree that ultimately the most important thing is preservation of life, and anything we can do to preserve life is something anybody in healthcare is going to agree is the ultimate goal.
Hey, thanks so much for listening to PodcastRx, a production of Diamond Pharmacy Services. While we're taking a break here, we'd love it if you took a moment to follow Diamond on one or more of our social media platforms. On the corporate end, you can follow us on Twitter @DiamondPharm. You can connect with us on LinkedIn via our Diamond Pharmacy Services company page, and subscribe to our Diamond Pharmacy Services YouTube channel. Our long-term care division has a Facebook page. You can find that at facebook.com/DiamondPharmacyLTC. They also have a LinkedIn showcase page. Just search for Diamond Pharmacy Services Long-Term Care Division. If you're a listener in our hometown of Indiana, Pennsylvania, our retail drugstores and medical supply stores also have a social media presence. Find them on Facebook, page name Diamond Drug Stores and Medical Supply, on Instagram @diamonddrug.medsupply, and you can also subscribe to the Diamond Drug Stores and Medical Supply YouTube channel. We appreciate your support of the podcast and would appreciate your likes and follows on these social media channels. Now back to the show.
Welcome back to PodcastRx. I'm Ashley Fritz. I've been sitting here with Chris Bender, who's a PharmD and part of the Diamond Pharmacy Services Drug Information Center. We've been having a very fascinating conversation about medication-assisted treatment for opioid addiction. And in our final segment, Chris, I want to ask you a little bit about some regulatory hurdles. So what kind of hurdles do exist if a prescriber or a medical team at a facility, if they want to start implementing this kind of medication-assisted treatment, what kind of regulations are out there?
Yeah, I think that's the most important thing to consider with this type of medication, because it's pretty it can be pretty restrictive. So like I said, we have the 3 different medications, and let's just start with the most restrictive, methadone. So methadone is the most highly restrictive. It is limited to patients who are in an OTP, an opioid treatment program. So that's why a lot of our facilities have a difficult time with using this medication, because only providers who are licensed within the OTP facility can prescribe and administer methadone. So that basically precludes most of our facilities.
Right.
So the way that they can work around that is if they have a partnership with an OTP, a methadone clinic per se, on the outside, often what they'll do is they'll send a representative from the OTP into the jail, and they'll provide what they call guest doses. But it involves a lot of transportation, a lot of security. You have to account for those doses as between leaving the OTP facility and entering the jail. So it can be pretty difficult. So that's why probably the easier of those 2 medications would be buprenorphine. But buprenorphine still has its restrictions as well. So most people are familiar with the X waiver. It's a special DEA license that is necessary in order to prescribe buprenorphine to patients. It's become a little bit more prevalent. However, our physicians across the country, there's still not enough licensed to prescribe buprenorphine for addiction. Anyone can prescribe buprenorphine for pain, but specifically for addiction, for opioid use disorder, you need to specifically have this XDEA number. Generally speaking, it's easy to obtain. It's regulated by SAMHSA, which is SAMHSA. And if anyone were interested who happens to be listening to this, you can just go to their website. They do have the enrollment in there. For physicians, it's an 8-hour training session of continuing education. That's the requirement. And then they've just recently, in the past couple of years, made it so that nurse practitioners and physician assistants can actually prescribe it as well. They just have to go through a little bit longer of a training period. It's a 24-hour training period. But the good thing is that by expanding it to multiple levels of providers, we're at least expanding access to it some.
That's very significant.
The problem is there are limits to the number of patients that any person can see and prescribe to. So initially when someone starts, when a doctor starts prescribing, they're limited to 30 patients. They can increase to 100 and then to a subsequent 275. But that's after a year of practice and then another subsequent time period between 100 and 275. So it takes some time to ramp up from 30 to 275.
Right.
So that's the difficult part. You're limited in who can prescribe, and even those who do prescribe are limited in the number.
Sure.
So that's what makes it hard.
I read, I don't have the exact source in front of me, but I read if every prescriber who's currently licensed and able to do this would prescribe their max that they're allowed for this method of treatment, we still wouldn't even touch half the people that need assistance with this issue. And it just shows that while this is an option and an outlet, it's certainly not going to be the fix-all for everything. And there's still much work to be done on all fronts, whether it's support groups and 12-step programs and counseling and whatever other things are out there that can help. Because at the stage it's in now, and I don't even know if in the near future we'll get there, that it's certainly not a fix-all at this point in time.
Yes.
But it certainly is something that it's good to talk about. And it sounds like it's heading in a positive direction in being more accessible to more and more people.
Well, and that's the thing. I do think that the DEA is also being a little bit more accepting of feedback, entertaining some ideas to possibly increase access. I don't know any specifics in terms, but I think that in order to have the most impact, it'd be prudent to minimize the requirements for the XDEA waiver, or just allow it to be prescribed off of a regular DEA number, or increase the limits of patients. I should note, though, that of the 3 medications, Naltrexone is the easiest to obtain.
And that is the blocker therapy.
The blocker therapy, correct. So it does not require any special regulatory items. It doesn't need to be prescribed through anyone special. Any nurse practitioner, PA, physician can order the medication, no problem. And that's one of the other drivers as to why it's a pretty popular option in our facilities, because you don't require special licensure. And it also doesn't have that stigma. So in that regard, it is kind of a win-win. And I can certainly understand why a lot of people tend to go down that route, because it's a path of less resistance, so to speak.
Chris, your role as a PharmD, you work with our drug information centers. You deal with clinicians all over the country frequently. Where do you kind of see your role in all of this?
Yeah, so it's great being in our position because we do get to interact with a lot of prescribers throughout the country. It's unfortunate that a lot of facilities want to come to us for a one-size-fits-all answer, and because I wish I could give them that answer,
right?
Because ultimately the answer, a lot of from a protocol perspective, for example, how do we treat all of our patients? Those decisions are ultimately made in those facilities. That's not something that, say, the 5 of us in the Drug Information Center can come up with for someone, because not every facility has the same personnel, access to medications and stuff. So we can't do an overall protocol as much as I think that would be cool and fantastic to do. But where we can come in is we can answer individual questions, meaning what would be a more cost-effective way to treat our patients? Is there a particular brand or generic that we can sort of funnel toward if possible? Because there are a lot of brand generics for buprenorphine products. So that's one way. We can also serve and facilitate for questions regarding pregnancy. Are there particular medications that we should be avoiding? For example, the Vivitrol injection hasn't been studied in pregnancy, so it's something that we shouldn't be using. The longer we haven't even touched on the longer acting buprenorphine products, which are really new to the market. The long acting injectable implanted rods. Those are a really hot item right now, but due to cost, due to lack of study in pregnancy, stuff like that, we can kind of help people discern when and where that type of product might be a good option. And also, too, just general questions as to whether or not it's safe to use in patients. So these medications should be used a little bit cautiously in liver hepatic impairment. So that's where we can come in generally with dosing questions. And finally, there are a lot of interactions with methadone and buprenorphine. Naltrexone, not so much, fortunately, but methadone and buprenorphine do have a very large drug interaction profile. And that's what we can do to kind of help providers understand, like, hey, what should we be wary of in this patient? Like, they're currently taking these medications. Is any of them going to boost the levels of the methadone and cause over sedation? Or are they on any medications that can kind of enhance the clearance of this medication and they'll be under medicated? Mm-hmm. So these are all the areas in which we can have a really positive impact.
It's a really important role because it sounds like it's definitely like most of medicine. There is not a one size fits all situation.
Unfortunately not. And
everything is a case by case basis. And something like this that has so many levels of complexity, I think having kind of that liaison is really, really important. I want to circle back. Our final question I want to ask before we wrap up the show today. We've mentioned the word stigma so many times in this podcast today. The stigma of those who struggle with opioid addiction, the stigma of those who choose to go the route of like a methadone treatment. How do you think we break those stigmas in the general public?
I think essentially it's going to come down to knowing people. Like I said, in being from a smaller town, seeing how it impacted the community, you never truly break those walls down until you know that it happened to someone. Knowing someone that it happened to, but they're not your typical user, that really helps to break the stigma as well. When you realize that it can happen to literally any one of us, it becomes much more powerful. And I just think that a lot of people coming out on social media, sharing their stories. Yeah. I know that there have been some news stories, I mean, not necessarily related to opioids, but I've heard of some celebrities going out on Instagram and talking about going to like an Alcoholics Anonymous meeting. Yeah. It's little things like that. And of course, the point is most of them want to remain anonymous. But the point is that some of them, if they so choose to share those stories, that can be really powerful because a lot of the people today, they don't know that so-and-so was dealing with that. And I think that by knowing someone, it makes it a lot more real and powerful and understanding that these aren't just bad people. It's just a good person that fell into a bad situation.
Yeah. I think it's always important to remember the humanity at the root of anything because you never know the full story.
Exactly.
So, Chris, I really appreciate you coming on the show today. This has been a great episode of PodcastRx, and we thank you for what you're out there doing and appreciate your time.
Hey, thank you so much. This has been fantastic. Thanks for having me.
Thanks.
This podcast features conversations with healthcare professionals. Their statements and opinions discussed herein are for informational purposes only. This podcast should not be considered professional advice and should not be used as a substitute for the advice of an appropriately qualified and licensed healthcare professional. Therefore, listeners must not rely on the statements made herein.
PodcastRx is a production of Diamond Pharmacy Services, the nation's largest correctional pharmacy provider. Find new episodes of the show on SoundCloud, Stitcher, and Google Play. And please subscribe, share, and leave us a review. Music by Maximiliano Silvera, sound expressed by Getty Images.